Hello, welcome to another edition of Science Room, brought to you by the Arthritis Foundation Mid-Atlantic Region. I'm Nick Turkas, the Senior Vice President of Health and Wellness for the Arthritis Foundation Mid-Atlantic Region, and I'm here today with Dr. Jim Oates at the Medical University of South Carolina here in Charleston, South Carolina. Thanks so much for joining us today.
My pleasure. Thank you for coming here and letting me talk about our research.
Your research today focuses on lupus and some novel ways of treating some of the conditions of lupus. We'd like to hear all about your project, how it came to be, and some of your findings. So please take it away.
Very good. Thank you. So our laboratory is very interested, as you had said, in lupus. And the two things that lupus does to patients that we're interested in is the kidney disease in lupus and also the heart disease that occurs in lupus. So today I wanted to talk a little bit about, just to give a little background about heart disease and lupus and what we know and a few of the unanswered questions. And then I'll give you a little bit of information about a study that I've already done that inspired the work that's funded by the Arthritis Foundation, and a little bit about that study, which is ongoing.
Excellent.
I have some slides that I'm syncing with, so occasionally I'll look over at the slides as I go through. I did want to give the viewers a little bit of background. Most of them probably are lupus patients, and a little bit of background on lupus. They understand it from their perspective, but from an epidemiologic perspective. It occurs in about 1 in 10,000 people, but it's a disease of women and women of color. So among African American women who are in their childbearing years, it's about 1 in 250. So it's a rare disease, but it's not a rare disease, depending on how you look at it. As I implied, it tends to occur in people during their productive years, or reproductive years, I should say. What interested us is an observation that happened in the 1970s by Murray Urwitz. He noticed that early in disease, people had difficulty with infections or complications from disease. But once clinicians were able to get them through that rough period, about 10 years later, they noticed mortality from strokes and heart attacks. And oftentimes this would occur when disease was quiescent. But why this happened was not clear, because when you look at traditional risk factors for lupus, when you look at traditional factors for atherosclerotic disease,
And that would be
heart disease like strokes and heart attacks. Things like diabetes and hypertension, family history, high cholesterol, high waist to hip ratio or body mass index were not as predictive. They're not perfect in even a non-lupus population, but in the lupus population they're not very predictive at all. So several groups have looked at this, and we're obviously very interested in this. I did want to step back and talk about, well, what is atherosclerosis? This is what's known in layman's terms as hardening of the arteries. It essentially is a process that occurs over many years and leads to the buildup of fatty plaques in your arteries. And if these sort of peel away from the artery because they're not very well formed, they leave a rough part on your artery, and you can get a clot there, and you end up having a heart attack.
folks that have had stents or angioplasty are familiar with this as well.
Right, they have atherosclerosis. And it can occur acutely when that piece of the plaque peels off, or it can occur slowly over time. So people that have angina when they're walking or exercising but they're fine at rest are experiencing that slow narrowing. So that's essentially what it is. A slide that I'm picturing here on the left is a normal aorta, and this is a cross-section where they've cut through the aorta. And you can see where a couple of arteries are at the bottom left are branching off of there. This is what an aorta should look like when it's healthy. On the right is your aorta on cholesterol, and here you can see it's almost completely covered with plaques. That's the yellow here. And you can also see some red areas where it's essentially unstable plaque, and it's likely to peel off there, develop a clot. We like to look at this lining of blood vessels kind of like Teflon. It prevents platelets, which are things that cause clots in your blood, from sticking, just like Teflon prevents your egg from sticking to the pan. And if you scrape away at your Teflon and leave an area where you've taken it off, the egg is more likely to stick. And this is a simplistic way, but a nice analogy of what happens in atherosclerosis. So the question is, what is it that makes that Teflon in your arteries unhappy in lupus? So lupus patients can have these what we call major cardiovascular events, or MCE, and this is strokes or heart attacks. About 1.5% will have one every year.
Oh, wow.
And if
compared to the general population,
much higher, five times higher.
Wow.
It's an equivalent risk factor or more to diabetes. So that's why we're interested in it. If you look across all lupus patients, about 40% will have some level of plaque in their arteries, even though they haven't had a clinical event yet. And that tells us that if folks live long enough or it progresses enough, that they will have an event ultimately. So our goal is to prevent those early lesions so that we don't end up with heart attacks and strokes. The next slide is a picture of a study done by Mary Roman and her colleagues that essentially looked at the plaque in the carotid artery, which is a good surrogate for what's happening in the heart. These fatty atherosclerotic plaques at different age groups. And the bars that are sort of in dark blue or turquoise are the lupus patients, and the light gray ones are non-lupus patients or controls. And you can see that at each decade, less than 13% already have plaque, and that's almost unheard of in people without lupus. When you get up to 60, 72% have some sort of plaque compared to 30% of the control population. So it's definitely an accelerated disease. Lupus patients themselves want to know, well, what can I do to prevent this? Several studies have been done that, not where they've given medicine and seen changes, but where they've looked at what medications patients are on and how much plaque they have. And one drug that seems to be protective, although we haven't proven this in trials over time, but is Plaquenil or hydroxychloroquine. Most studies show a signal there when that's looked at. And giving cyclophosphamide in patients that require it seems to be protective. We don't know why. Is it because it does a very nice job of preventing active disease, and that active disease may lead to damaged arteries? We don't know. Drugs that are associated with increased heart disease or atherosclerosis are prednisone and azathioprine. Prednisone, we're not sure if it's a direct effect of the drug on the lining of the arteries, or whether it's indirect because it causes hypertension and diabetes and weight gain and all those things, and that those things may contribute.
But it has an anti-inflammatory effect, which is associated with heart disease.
It's a complicated story.
No kidding.
Or is it a surrogate for people that have active disease, and they're more likely to get long-term prednisone?
Are there cardiovascular drugs that people take to keep their cholesterol down would be helpful?
Right. So a lot of studies have shown an association with atherosclerosis, and the study that I'll allude to that we did showed a trend towards an association of high cholesterol with atherosclerosis. And it's recommended that people take a statin to reach LDL cholesterol goals of those that you would want to achieve in someone with diabetes or high risk for heart disease, so an LDL of 100 or less. Studies have been done to look at whether that's effective in preventing events or preventing the progression of atherosclerosis, and I think the jury is out on that, whether it's an insufficient number of patients or not selecting high-risk patients initially. It's not clear. I think further work needs to be done on that. But currently we're recommending people take a statin like Lipitor or one of those drugs if their cholesterol, LDL cholesterol, is over 100. So many studies, like I said, have looked at this, and some associations that occur. This is not an all-inclusive list, but the longer you've had lupus, the more likely you are to have atherosclerosis. This appears to be independent of your age, number of years on Earth. So somebody who is 40 years old and has had 30 years of lupus is more likely than somebody who's 40 years old and has 10 years, has had 10 years of lupus. Kidney disease and lupus is associated with it, just like non-lupus kidney disease. What we call the consequences of oxidative stress, this LDL cholesterol, which we consider bad cholesterol, when it's oxidized, it's more likely to cause trouble and cause an inflammatory reaction in your blood vessels than regular non-oxidized LDL. There is HDL is the so-called good cholesterol. It helps you clear LDL or to clear cholesterol from plaques, but it can become dysfunctional in lupus when it itself doesn't do a good job of preventing oxidation of LDL. So the protective LDL is not as functional, and the bad oxidized LDL seems to be higher in lupus patients. Not something we looked at in this study, but it gives us a general sense that oxidative stress is important. And then anything that mediates blood vessel function seems to be associated, and I'll get into that in a little bit. This next slide is on the left a picture of what a normal artery would look like. It's sort of a cross-section in and these yellow pinkish colored cells on the inside are endothelial cells, and this is that Teflon that I was talking about. And they're smart Teflon. Not only do they prevent things from sticking, but they actively prevent inflammatory cells from coming in, and they actively prevent clot. And they actively allow the blood vessels to open up when it's necessary to provide blood flow to an organ. Whereas on the right, this is a vessel with atherosclerosis, and the endothelial cells, or the Teflon there, has actively called inflammatory cells into the area. It's allowed them to stick to the lining and migrate in underneath the layer there, and allow this oxidative reaction that we talked about before to occur, and a plaque forms when you have dysfunctional endothelium. So this lining of the arteries is very important in preventing atherosclerosis. So that's our main focus, is what causes this endothelium to be dysfunctional. The next slide sort of go over what I mentioned before, but a key mediator of this is nitric oxide. And that's actively released by the endothelium to do all these nice things that I mentioned earlier. And when that doesn't occur, in pathologic states, you get more inflammatory cells, more clot formation, and the vessel can't open up. And there's a test that we're doing in our study that looks at that in a human being rather than in a cell culture. So what's known in lupus is this ability to dilate the blood vessel to get blood to the organ when it's necessary is impaired. And there's a test called flow-mediated dilation where you put an ultrasound on somebody's brachial artery in the arm and look at the blood vessel over time as your heart is beating. They blow up a blood pressure cuff and then release it, and that should stimulate that artery to open up a little bit. And the ultrasound can measure that. In lupus patients, that opening up is not as high.
Do most lupus patients receive that sort of test?
Do they get that kind of test? No. Right now it's just research. Would I like for that to happen? Yes.
Oh, interesting.
Because someday I envision a world where we don't give statins to everybody that has lupus and a high LDL. We give statins to patients that have a high LDL and this problem with their blood vessel function. So you're targeting a high-risk population, so you're only exposing them to the drug because they're the ones
And
that
it's not an
need the
invasive test?
No, not at all. It's an ultrasound, just like an ultrasound of the heart or when a woman has an ultrasound of her abdomen for a baby. So it's completely painless. And you sit in a nice, quiet, dark room while it's happening. But when this is not functional, it's associated with more plaque, and it's associated with more bad outcomes, like heart attacks and strokes. So it's a good surrogate for predicting bad outcomes in an individual. So the first study that we did was asking the question, can we predict who has more plaque without doing something invasive like a cardiac catheterization? And we were looking at measures of oxidative stress, novel risk factors that I'll get into in a moment, and the traditional Framingham risk factors, and those are the ones that I mentioned: high blood pressure, diabetes, obesity, family history, etc. And we wanted to develop some statistical modeling to see if we could predict from all these variables who's going to have more plaque. And we enrolled 50 subjects who did not already have a history of stroke or heart attack. We wanted to predict subclinical disease before an event happened. They all had lupus. And I have a picture of Dr. Kamen because she inspired me to look at vitamin D in these subjects. She's a colleague of mine in the MUSC Lupus Erythematosus, or Muscle Research Group.
A great friend of the Arthritis Foundation.
Yes. And we looked at medication use like hydroxychloroquine and azathioprine and prednisone, as well as markers of activity and damage and biomarkers of oxidative stress. I won't talk about the oxidative stress today. It's a great interest of mine, but it doesn't lead into that project that's funded by the Arthritis Foundation. David Spence is a colleague up in London, Ontario, who has an atherosclerosis or vascular prevention clinic. And he does this measure in his patients, and he stratifies people by their risk according to this. Actually, he looks at plaque rather than flow-mediated dilation, and he targets people with plaque and actually can see regression of plaque with treatment. So it's a nice concept to be able to target people who are high risk. So we looked at this amount of plaque in the carotid artery as a surrogate for plaque that's in the heart. And the next slide shows on the bottom, which is known as the x-axis, the age of the different patients. And on the y-axis, it shows the amount of plaque that's in your carotid artery. So the more plaque is higher up on there. And you can see a line, a black line on the bottom there. That is the normal progression of plaque over time in women. And the dotted line is the normal progression of plaque in men. So it allows us to compare our lupus patients to age and sex-matched controls. And the lupus patients are in the purple triangles there. And you can see that there is a group of individuals in that oval there that are above what you would expect individuals the same age and sex. And then there are individuals who really don't have much atherosclerosis at all. So the study was designed to look at the difference between those populations to see if we can predict who that is.
Interesting.
So I won't go into the details of the statistical analysis or anything, but several things came up in the analysis that seemed to be associated with atherosclerosis as measured by this plaque area. One was age, and that shows up always, and you can see that in that line that I showed you of normal progression in men and women. How long you've had your lupus, and this is, we've seen this in other studies. The novel thing that came up in this study was vitamin D insufficiency was associated with higher plaque, and markers of oxidative stress are also associated with it, and that goes along with studies by Beverhan and other groups that have looked at this phenomenon. Use of an ACE inhibitor is associated with less plaque. ACE inhibitors are antihypertensive drugs or blood pressure drugs that we give to patients typically if they have renal disease. And it's things like captopril, enalapril, lisinopril, benazepril, anything that ends in pril that's a blood pressure medicine is probably an ACE inhibitor. And that seems to be associated with less plaque. And the use of Plaquenil, once again, hydroxychloroquine, showed up in our group, just like others, to be associated with less plaque. Whether it's causative or not, we don't know, but it's interesting to look at. And there were trends towards having a low LDL and having less plaque, higher LDL and having more plaque. But it wasn't statistically significant in this group. So we began to ask the question, if low vitamin D is associated with more plaque, can we take an individual who has low vitamin D, give them back enough vitamin D to bring their levels to normal and see better blood vessel function? So someday we might be able to prevent heart attacks. Vitamin D deficiency is something we see quite frequently these days.
Yes.
We evolved as human beings as living outdoors, and as a culture we've moved indoors and
wear more clothes.
Wear more clothes, yes. And we ask our lupus patients not to go out into the sun.
Exactly.
And lo and behold, the best way to get vitamin D is from sun exposure. Now we're dependent on diet. So we get all of our vitamin D essentially from diet, and except for surfers in Hawaii, they have very normal levels. So among people with dark skin in our population, when we check vitamin D levels, they're almost always low. So we thought that this may be a good intervention where a large portion of our population may stand to benefit from repletion, but we don't know whether that works, so that's why we designed the study. Another rationale for the study was one that was done in vitamin D deficient diabetics. And they took individuals with low vitamin D and diabetes, and gave them enough vitamin D to replete their levels to normal. And they looked at endothelial function by flow-mediated dilation, this blood pressure cuff ultrasound measure. And on the left side of the screen, you can see that they were able to replete levels in most patients. On the right side, before treatment and after treatment, you can see in most individuals, you actually saw an increase in blood vessel function as measured by this FMD. So we thought maybe this could happen in lupus patients as well. Another rationale is when you culture endothelial cells, this Teflon lining of your blood vessels, with increasing amounts of vitamin D on the x-axis. On the y-axis, you see increasing in nitric oxide production. And this is that mediator that I talked about that helps prevent inflammatory reactions and plaque formation in blood vessels. So those two things together, along with other evidence, made us think maybe this was worth studying. So the Arthritis Foundation was kind enough to give us a grant to look at 32 patients with lupus who have low vitamin D and randomize them by the flip of the coin, essentially, into an equal number of patients who receive what the FDA recommends of vitamin D versus what we think will be necessary to replete them to a normal level. So a low versus a higher level of vitamin D. And we'll look at this flow-mediated dilation measure at baseline and then again at 16 weeks. And we think that's about how long it takes for most people to replete, so it's not a quick process. So our goal is to see if the people on high dose have better restoration of endothelial function than those who are on the low dose.
Any risk to having too much vitamin D?
So there are theoretic risks. There are studies that have been conducted to look at much larger doses than what we're giving, and they haven't seen a problem. But you could envision higher calcium levels in individuals because vitamin D is very important for bone and mineral metabolism. So it helps you hold on to your calcium and store it into bones better. And so there is the potential for kidney stones. That's been one risk factor, and we do look at that in our patients in the study before and after just to make sure. Haven't seen any signals yet, but it does restore function of blood vessels. So individuals who are hypertensive on blood pressure medicines may actually notice a drop in blood pressure, and they may need to take less blood pressure medicine as a result. And we've had one patient in our study who noticed that already, so we had to peel off one of her blood pressure medicines and we started the vitamin D. So this next slide is actually a picture, and a sort of a diagonal, two light stripes going across the screen are both sides of a brachial artery in cross-section. And you can see it outlined by the two parallel lines, and the distance between those lines is the diameter of the blood vessel. And you can look at it through each heartbeat, and that's a little EKG on the bottom to allow us to gate that. And you can look at that over time and get a baseline and then do your blood pressure cuff measurement and get a graph that looks like this. So at the bottom left, this is time on the x-axis going from left to right, and the diameter of the artery on the y-axis. And what you can see is that you start at a low level here and very rapidly rise to a higher level. And the difference between that high level and that low level is your flow-mediated dilation. And we anticipate that that difference will be larger in patients who we've repleted. But we have to do the study to find that out. The study is still ongoing. We're in the early stages of enrollment. We are a victim of our own success. In our clinic, we recognize vitamin D deficiency, and we've been repleting our patients. So it's becoming harder and harder to find people who are deficient.
New patients, possibly.
Yes, new patients. So we're very hopeful that we'll be able to complete enrollment and have an early signal. This is a pilot study, and what it's meant to do is to allow us to see what's called an effect size. What might the difference be between those who are treated with high levels and low levels, so that we can design a larger trial across multiple centers to see how well this works.
So if I have lupus, should I run out to Walgreens and buy some vitamin D supplements and talk to my doctor about that, or too early to tell?
Well, it's too early to tell if that's going to prevent heart disease or if that's going to help endothelial function. But vitamin D is important in all sorts of processes, including bone metabolism. So if you are at risk for having a low bone density, I would certainly talk with your doctor about that. Theoretically, it should work. We're doing this study to see if it does. The risk, it seems to be low for taking vitamin D, but one approach would be to measure your level, calculate the dose that you need, take that dose for 4 months, and then check your level again. And that way you'll be sure that you're not overdoing it.
Always a great idea to work with your doctor on making sure you get that right.
Absolutely.
That makes a lot of sense, and it's interesting that this is a non-drug intervention and a seemingly inexpensive intervention for folks. So a lot of times when we talk about research and science, we often think about new devices or new drugs, but this is a way of changing our diet or using a supplement that could have a very significant effect on your chances of having a heart attack or stroke or any of those other nasty side effects of lupus.
Yep, that is what we would like to determine. One interesting thing about vitamin D, we think of it as a vitamin, but it is a hormone, and it's sort of in the same class as steroids. It has effects on multiple pathways that are difficult to list on one piece of paper. So while it is a supplement that our body normally makes, we're sort of dependent on that supplement now because of the way that we live now. But it is an inexpensive way, and I'm very hopeful that we'll be able to show whether it works or not for heart disease and lupus.
All the more reason for more research for the treatment of arthritis and related diseases like lupus. Why we have this program is to help people understand that researchers like you are working all across this country to find treatments and cures for arthritis and related diseases, and how important arthritis research funding is for the smart folks like you. So we want to thank you for your interest in finding treatments and cures for arthritis and related diseases.
My pleasure, and thank you for letting me talk about our research once again.
My pleasure. Thank you once again. This has been Nick Turkas with the Arthritis Foundation Mid-Atlantic Region here in Charleston, South Carolina with Dr. Jim Oates. Thank you all.
Goodbye.